Well, welcome everyone. Thank you for joining us for this week's Caring for the Caregivers special series, presented by IHI in partnership with Wellbeing Trust. I'm the Joy Portfolio Director here at IHI. I want to just give you a few practical reminders. When you're chatting, please chat to all participants. This can be a little bit confusing because there's multiple options, and sometimes it defaults to the host only. But when you select all participants, it's the only way for other folks, including the speakers, to see your comment. If you have any technical questions at all, just chat directly to Eleni, and she can get you sorted. So let's get started. Experts are predicting a significant second curve of mental health sequelae following the pandemic among both healthcare workers and the general public. Studies have documented this, showing higher rates of depression, anxiety, insomnia, and distress among healthcare workers. There have been some good resources and recommendations published lately to help healthcare workers manage stress during the pandemic. But for a lot of them, there's a tendency to place the burden on the individual alone. And at a minimum, it's important that remedies acknowledge the shared responsibility of the system for creating the conditions where fear, anxiety, and burnout occur in the first place, and offer opt-out or systems-wide solutions that are accessible for staff. So today we're going to zero in on what one such intervention might be. This is our fourth installment in the Caring for Caregivers special series, and on this program, we're going to narrow in on peer support. Popular among law enforcement and the military, peer support systems are supported in the literature, and they have been well cited for meeting ongoing behavioral health needs for both patients and care team members. And they're also a vehicle for culture reform in overcoming stigma by normalizing conversations about traumatic experiences. Together with our experts, we're going to explore what is peer support, why is it particularly helpful amidst the pandemic, and how can peer support and similar approaches prove to be sustainable solutions to the challenge of healthcare worker burnout. In support of this approach are two experts on the topic. Dr. Joe Shapiro, Associate Professor of Otolaryngology at Harvard Medical School and Senior Faculty for the Center for Medical Stimulation in Boston, and a longtime mentor of mine, and Dr. Christine Hein, who is the Chief Wellness Officer and Associate Medical Director for the Department of Emergency Medicine at Maine Medical Center. And welcome back, IHI's Dr. Don Berwick, who's our regular expert panelist on these virtual learning hours. Hello, panelists.
Hello, thanks for having us.
How are you?
Hi, thank you.
Thanks to you for making the time to share your expertise today. And hello, everyone joining us. As usual, you're going to hear from our panel for about 30 minutes, and then we're going to turn to a Q&A. But feel free, of course, to chat in questions and exchange ideas with one another throughout our hour together. So Don, if I can, I'll start with you. We know care team members need more help and support now more than ever for managing mental health, as mentioned. But the same stigmas against seeking treatment that exists in society are also prominent in the medical profession. Some of this has been attributed to this kind of culture of infallibility in medicine. Maybe there's fears in reaching out for care from a colleague. Maybe folks are just thinking they don't need it. Can you speak to us a little bit from your experience about why the stigma seems to persist in healthcare around accessing the same treatments that providers prescribe for behavioral health support?
Well, thanks, Jessica. And let me first extend my thanks to Dr. Shapiro and Dr. Hein for joining us. It's going to be a thrill to listen to them. You know, I was trained in medicine and then in pediatrics, and I remember the training in which there was a premium placed on being tough and self-sufficient and being able to kind of get through the roughest moments on my own. And I do believe that there was a subliminal signal a bit about weakness if one expressed distress, despite the fact that I know we were all distressed. We used informal peer relations to help support us, but no, it was in the culture that you just do your best. I think part of it comes from a good side of professionalism, which is dedication to patients, that we're there for them, and that there's a certain expectation of a kind of selflessness and commitment to patients. Number one, I remember a mentor of mine saying, never lay your trip on the patient. That was a pretty clear signal. But we've known for, a century that we need support in our work. Very famous Tavistock groups in London, started by a famous psychiatrist in England, were exactly that, peer support groups to talk about rough times and difficulties, not just with patients, but in life. And I've seen through my whole career in the background, the existence of these kind of support systems. I'm sure Joe and Christine will talk a bit about the background of this themselves. But I welcome it. I think this is a time to take a deep breath, realize we are all human beings. We're in this together, and we better find ways to support each other. And I'll also say that I think in medical education, I've seen evolution. A lot of younger physicians are now in training programs, which really are attending to their needs. So I think we're in a good stream of effort here now. But now we'll hear from Joe and Christine about some of the more serious ways of thinking about it now, and hopefully these will outlast COVID. These needs are going to be there. They have always been, and they always will be. Thanks a lot, Jess.
Thanks, Don. That's a perfect segue, actually. I was going to ask you, Joe, you've been a longtime thinker, a researcher, and advocate for building professionalism and peer support programs organizationally. Can you help us just kind of with some definitions? What is peer support, and why is it particularly helpful right now?
Again, thanks for having me. And Don, your setup is really important. That background is so true because we all exist in a very strong, both cultural and structural system that really has a huge influence on the work that we do and the outcomes of the work that we do. And so culture can be very supportive of where we want to be, but it can also be very undermining. And I think you just really elegantly explained how that culture can be both positive but also very undermining in terms of our accessing the help we need, and also the sense of humanity that we all should honor in each other and ourselves. So peer support comes from as you said, Jess, the first responders have a very robust peer support system. The idea is that certain professions, and certainly we could all relate to this in healthcare, have a culture that really has overvalued, I would say, the putting your head down and getting your work done, and which is fine in the moment. Obviously, day to day, that's what we need to do. But the idea that you would not have any effect on your emotional or physical or mental well-being, after not processing some of the things that we see because of the profession we're in, is just so misguided. And there's plenty of data to now support that it's misguided not to be there and not to help in these moments. But we're battling a culture that's put and some cultural and structural barriers in the way of that. So peer support. We looked at this in a study because we wanted to understand with emotional stressors, and this was a study particularly of physicians. And I think physicians, I'm generally talking about the whole healthcare team, but there's some specific needs unique to the culture of physicians that, so I think some of the studies are on physicians in particular. But as ours, this particular study was, that showed that in response to emotional stressors, physicians wanted to talk to colleagues. And so peer support would be support from colleagues, not specifically non-mental health professionals. Why? Because people feel like a lot of the stressors they're experiencing are from their, kind of occupational hazards rather than I'm having a mental illness issue. We also know, of course, people do need professional support from mental health practitioners sometimes, absolutely, and other forms of what we call further resources. But what formal peer support does is it bridges the gap between that sort of informal, hey, how's it going, which is, I would call necessary but not sufficient, and then actual formal professional resources. And it's well accepted to be able to have conversations, even about very emotional and emotions and also vulnerabilities with your peers because you feel safe. So it's really psychological safety, I think, peer support provides.
Thank you for that. I see you have here some components of it. Can you tell us a little bit about what a good peer support program looks like?
Yeah, I think that going back to the other slide, I think some people want to understand, like, well, how's formal peer support different from just like, hey, how are you doing, or how's it different from therapy? I think I'm a surgeon. Nobody's going to mistake me as a therapist. So I think that's pretty clear. These interventions are on the level of a colleague to a colleague, but the most important principle is loving presence, right? Really giving your loving presence to your colleague, which is not easy to do. We don't do that often. We don't have a structure for that. We just don't. It just isn't part of our lives essentially. And so being able to do that in a very focused way is a gift in and of itself to a colleague. If that's all you do, that's a beautiful thing. But some other things that I mentioned, one is psychological safety, and the other is this non-judgmental curiosity and problem-solving guidance, because as you mentioned in the introduction here, Jess, one of the things that is true for us struggling to deal with emotions around COVID and other events that and circumstances in healthcare is that there are some individual things that we can do. So our own coping mechanisms need to be kind of activated and are often not activated when we most need them. And also we need help navigating the system, because there are going to be systems issues that come up as the triggers for some of the emotional distress. And I think in peer support, the focus is on both. What are your personal coping mechanisms, and also how are you struggling within the system, and how can we help you problem solve that? I'm not going to solve it for you as your peer supporter, but I'm going to help you think of who could you go to, or what else could you do, or how could you make your shifts better, or your responsibilities more feasible for you. And so that's a really big component. And then helping people keep their emotions and their reactions in perspective, which is, you're suffering because you care, not because you're weak, and not because you're abnormal. You're one of us. We are all feeling these things to different degrees. And the other, on the next slide, I just talked about some of the components of a peer support program that just need to take into account overcoming those barriers that are there for getting support. So one is, don't make it so that people have to say, I'm hurting, help. If you have a program, you should absolutely respond to anybody who's reaching in, if you will, saying, help, I'm suffering. But what we found, especially with physicians, is if you just ask somebody like, hey, how are you doing? People are going to say, I'm fine. I'm handling it for all those reasons that we talked about. So that you need to have a way of saying, look, we have this program, and I'm part of the program. I'd be happy to talk to you about what to do. Again, rather than simply waiting for people to say, help, I can't do it anymore. It's often very down the line in terms of stress levels. And then the other is so many ways we can integrate, formal peer support is that I'm going to offer this conversation for you in a dedicated period of time. Instead of, seconds or a minute, more of a sit here for an hour together at a time that's convenient for you. And I mean, really sit. But also integrate concept that we have some emotions into our rounding, even our grand rounds or our Zoom meetings, is to do a check-in with people saying, hey, how was the week for you? And then if people, need to share more, say, why don't we do a group meeting to talk about some of the emotions, but have it integrated into the processes that we normally have, like debriefing a shift, to say, how was that for you? And then if people are, anyone is saying, this was particularly hard for me, is making sure they get connected with a peer supporter. And of course, if they want further resources, facilitate that connection.
Is that hard to do right now? I mean, I could see both sides of it, where it's actually kind of therapeutic to be of service to someone else. But right now, when everyone's going through it, is it hard to be an available peer when you're holding so much of this as well?
Well, that's a very important question. I think when you operationalize a program like this, you have to make sure that you don't burn out the peer supporters. That would just be horrible. And so, there are ways in play that in many programs that have helped establish programs or organizations, we put in place some kind of either rotation of who's available, but also more just asking different people to be available at different times for different events or different circumstances. So I do think that's important. What's really striking, Jess, is having done a ton of peer support myself for my peers, is yes, it does take my time, but it is so replenishing. It doesn't drain you. I think all peer supporters should be supported as well, but it's surprisingly, it feels good to do. And it's such an honor to have your colleagues share with you and to be in that position of being able to do that. So it sounds like it would be a big drain, and you certainly don't want it to happen, put the burden on for someone to do it too often, but it's really replenishing.
Yeah, I think that speaks to this quote you shared with us here.
Yeah, this comes from Adam Hill, who he went through a journey of addiction as he was in training and then a faculty in medicine, and he just talks about this. The ideal, if you will, what John Lewis, the wonderful civil rights activist and senator just died, would call living as if, and I would say this is the as if, that we would have a process of self-discovery, self-awareness, and processing emotion that can open experiences of gratitude and grace in your life and forever change you by the act of leaning into them. And he writes about to truly feel the emotions, connect them to your own human story, explore the reasons for them, for their salience, and grow by engaging them. And that is actually what happens in peer support. Some of it is logistical, like helping people navigate the system, and a large part of it is also just helping people hold their emotions. And I just want to add something to that is I've really noticed, and I'm going to say physicians in particular, are so guilty about feeling any gratitude. And so what I do with peer support is, a lot of it focuses on some of the negative emotions they're feeling, like they're feeling guilty, they're feeling grief for all the losses, they're feeling fear and anger about the system and how it's not, how it's fallen upon the Black population to bear, all sorts of health disparities. But with that, most of us have also gratitude. Like there are beautiful things that are happening too. And so I just try to point out in peer support that it is okay to hold both grief and gratitude, to hold positive and negative emotions, and that neither cancels the other out. They're both real and important. And I say this, I emphasize it because that's not how we're enculturated, certainly not in surgery. It's just the idea where emotions are irrelevant and if anything, they're in the way. And sure, like again, acutely, of course, it's not about us, it's about patients. But as humans and sustaining our joy in work, which IHI has been so instrumental in helping us think about is, how do you sustain your joy if you aren't connected at some point to your emotions? And the answer is, of course, you can't.
Yeah. Thank you for that. And to give us an example of how this has played out in action, Christine, you've led medical staff well-being at Maine Health since 2014.
Yeah.
That's right.
Yeah. Yep.
And one of the pillars of your program is a peer support program. So I'm hoping you could tell us a little bit about how you got it started, what the journey has been like, and how it's played out during the pandemic.
Yeah, I'd be happy to. First, I do want to thank everybody for the opportunity to be here today, and thank Jo Shapiro for all of her sharing of her knowledge over the last 8 years, I think, since we met. And I also wanted to extend my gratitude to our peer volunteers who have just graciously donated their time over the last 6 years and continue to do so. And we continue to have people raise their hand and say, I'd like to be a part of this program to help my colleagues. So I really appreciate that. It's been quite a journey, I can say, and it all starts with the culture of an organization. And I think when we started thinking about this in 2012, we had a culture that was saying, what is peer support? It wasn't even familiar with the concept. And now we have a culture where people start a sentence saying, I need peer support. And then that's a signal to sit down and put aside everything and listen to what your colleague or your friend or whoever you're speaking with is saying to you, because it's vitally important that they have our attention. And so our process did begin about 8 years ago when our medical staff president and the chairperson of our Provider Health and Resiliency Committee decided to really turn our attention and focus on investing in provider wellness at Maine Medical Center. And the first thing on the list was to develop a peer support program. So we developed a small group of individuals who, like, if you look at the next slide, I think we're kind of living according to the phrase, every system is perfectly designed to get the results it gets. I mean, and really believing that perhaps we could get different results if we designed a different system. So we developed a small steering committee or steering group that actually met with Joe and over the course of probably 18 months on multiple occasions in small group settings and also for larger presentations to make the case for peer support and also to understand the importance of it and the impact not only for us as providers, but also for our patients in terms of quality and safety. If you look at the next slide, I reproduced this from the National Academy of Medicine's Clinician Wellbeing site. And this picture is captivating for many reasons, but I think it really, to me, holds the two sides of what it means to be a physician or provider in today's medical society, where we have the expectation of ourselves and also our patients have the expectation that we're going to have this more robotic, automatic response, which is extremely beneficial in times of high stress. But then if you look at the other side, we're human, and under our skin, is the same thing as all of our colleagues and our patients. And I think that's the side that we haven't been attending to historically in medicine. And so we were very excited to develop a peer support program. And we really spent, as I mentioned, about 18 months to 2 years developing the infrastructure for the program, which sounds like, okay, well, what does that involve? It was really quite a process to understand what the scope of the program is, that we are providing emotional first aid out of relevant experience that we have as peers, and that we're not providing counseling services or professional mental health services. And so to do that, to develop a program that could do that well, we really needed to identify program champions and other key individuals who would support the process and believe in the process and help with that culture change that's so important. So that involves selecting a program director and identifying, selecting, and training the peer volunteers. And it's really important to identify the right people for those positions, because there can be a lot of people who are wonderfully qualified to be a peer supporter. But if they're the chief of a department, they may not be the best person to provide support, because there can be concern about people feeling safe disclosing their kind of personal feelings about a situation. So we underwent a training process, and then also during that time, we're really thinking about the referral process and what that would look like. Because as Joe mentioned, some people may reach into the program, but certainly that's going to be the minority when you start a program. And so you have to have a pretty mature understanding and development of how you're going to reach out. And so for us, that involved a few different prongs. We partnered with our risk management department, who was extremely supportive about this idea, and got buy-in there for them to refer individuals to our program who were going through a risk management process. Now, that being said, it's really important for those individuals to understand that peer support is not tied to the risk management process. So it wasn't a mandatory part going through risk review, and there's no feedback to risk management about what is discussed. It remains all confidential. But that was a great place to start to get referrals to our program and identify people who are at risk. We also have always accepted referrals from colleagues and then from individuals themselves. And it's interesting, a few slides later I'll show this, but our buy-in to the program clearly developed over a course of time. And whereas many of our referrals initially were from risk management, and those individuals said, thank you for reaching out, but I'm just fine. Now, most of our referrals come from colleagues who are concerned or from individuals themselves, and the buy-in has significantly increased in the last few years. So along with that, we had to think about how were we going to do continuing education and advocacy for the program, for the peer volunteers, and for our colleagues who we're trying to support. And so we have set up a recurring meeting for our peer volunteers on a quarterly basis where we come together to discuss our experiences of being peer volunteers, not to discuss what has been shared with them, but to review how effective or ineffective you may feel in a case, and how we can kind of problem solve to really provide the best support that we can for our colleagues. And then we worked with our marketing and communications department to get the word out, because you could be talking to a group of physicians and have people in the room raising their hand and saying, I have never heard of your program. Can you tell me more? And they're sitting next to people who have accessed the program. And so we really wanted to break down the barriers of receiving peer support and kind of sharing that experience and sharing what some of the benefits of it could be. And then probably another piece that isn't immediately obvious but is vitally important for a program to succeed is having some sort of referral process when it becomes obvious that the individual could benefit from additional resources. So whether those are community resources, professional counseling, ongoing relationship with someone that's going to be able to hear their concerns. So we developed a list of individuals who were willing to work with healthcare providers within our community. And it can be really important that you have people from outside your health system as well as within your health system to fill those roles, because everybody has a different set point for what makes them feel safe. And we wanted to attend to everybody's concerns about confidentiality and, as Joe mentioned, kind of that psychological safety and what really allows you to share. So we launched our program in August of 2014. And I can show you, if you want to look at the next slide. When we started, we were the only program in the state, and now those yellow stars represent other programs that are currently in existence and fully functional. After launching our program, we went around and did some training around the state, which was not us, putting that upon other sites, but actually there were requests that were difficult to keep up with about, oh my goodness, we heard that you have a peer support program. We think this would be great for our staff. Can you come help with this? So currently, there are multiple peer support programs around the state throughout the Maine Health system. And we did develop a Maine Health email that is staffed by myself and the Director of Peer Support at Southern Maine Healthcare on alternating months for sites that don't have a local peer support program. So we can at least provide some level of support and maybe identify other resources that could be helpful.
Great.
If you look at the final slide, oh, I'm sorry, Jess.
I just don't want to skip over this, outcome slide. It seems pretty interesting.
Yeah, so this, I love this slide. This is from Stephen Swenson and Tate Schonefelt, and looking at some of the actions that you can do to enhance professional joy and satisfaction and also try to mitigate burnout. And if you look at peer support specifically, I think it hits 4 of these different actions in designing a system that addresses human needs. Certainly peer support is addressing the human need for social connection and decreasing isolation, which is a huge driver of burnout. Building social community, reducing or preventing entirely second victim syndrome, and then bolstering individual wellness, because a lot of what we discuss during a peer support session is accessing tools that the individual already has, and kind of encouraging them to rely on the things that have worked for them in the past to get through difficulties. So I just like looking at, one program can hit all of these different areas. And then my final slide, the blue is the number of people who were reached out and accepted the offer for peer support. Red was the number of people who said, no, thank you, I'm doing well. And gray are that I didn't get feedback from the peer volunteers about whether they accepted or not. And if you look, you can clearly see over the course of the years of the program that people have bought into the concept of peer support much more so than when it first started, where we really had difficulties, I think, with people trusting that the program is actually just here for them, and it's just part of the fabric. So we introduce this now during our onboarding sessions for new providers and offer it as, this is just what we do. It's nothing that if you get reached out to by the peer support program, you're that kind of outlier case. This is actually just what we do. So it's been a really rewarding process.
Wonderful. Thank you for sharing that. I'm wondering, you're getting some great questions that I'm going to raise up in just a minute, and I want to hear Don's reflections as well. I'm wondering, a lot of times with programs like this, it's hard to get organizational buy-in because there's cost associated with time that it's taking folks to do this work. Did you have any challenges with that when you were getting it started? And if so, how did you overcome it?
So honestly, because it was an initiative that was backed by the medical staff president and risk management and other leaders of our organization, we didn't have a significant amount of difficulty getting buy-in. I think that since that time, there's been just an immense body of literature that shows the return on investment is quite remarkable. And to honestly start a peer support program, the peer volunteers are donating their time. And we started out with a very, very small amount of time for the program director that was dedicated to this. So it was not a significant expense for our organization. And I think that's where, when you're looking for key individuals to lead the program, you do want to identify people who have a passion for that work and are willing to sort of build something and then ask for more as the program is demonstrating its value. And, these programs do demonstrate their value.
Yeah, go where there's willingness.
Yeah.
You're on mute.
Yeah, classic Zoom, tele, whatever mistake. So, Christine, thank you. It's such a pleasure to see just how far you've taken this with your leadership. It's really, I love it. It makes me feel so great. Okay, so I just wanted to respond to what you asked, Jess, about that buy-in. Something that, in helping programs get started, first of all, Christine's group was one of the earlier ones that I worked with, and all that lead-up time was really, it was just, they just sort of sowed, this beautiful field for this to grow in. What's really been interesting is, as both of you point out, there's, and Christine just said, is there's just so much literature now about what happens when we don't pay attention to the well-being of our healthcare providers. And that's actually how I got my organization that I was in for 35 years to start this, and I have helped other leaders at other organizations do this, just to say, look, there's no perfect answer to this, and the well-being efforts are going to need to be multifactorial. This isn't the only one. That said, we know from data that this is one that physicians in particular, and also other studies showing other healthcare practitioners want as well. And we also know what happens when you don't do it. And so that is a big one, getting buy-in from all sorts of leadership where they're like, well, is it worth it? And the answer is, well, here's what happens when you don't. And the other thing, somebody asked, if this is okay, can I respond to the chat?
Sure, yeah.
Okay, thanks. Sorry, back on this question of like, well, how much does it take to get started? What's been amazing about COVID is, so I've have all these, organizations that have been in contact with me. Some had already started peer support. Others were thinking of doing it and had me coming out there, in the fall, right? This coming fall, and some I'd never heard of. I had all these contacts, people calling me saying, we want to start this now. And what's amazing is, it doesn't, I think the problem with having Christine talk about this is being like the top of the top, the most beautiful and, thoughtful program. But you could start with basically, it really isn't expensive to start. You just need someone who's going to run it, and basically, and I, this is what I help programs do, is just, find the people by nomination for who would be the peer supporters, and then train them. And then make sure you have the resources together of where they would, further resources. It does, perfection is the enemy of good. I've helped organizations start peer support programs within a month, as opposed to the, several years that it used to take. So that's pretty cool. That's a positive thing. And the other question that I just want to answer in the chat was, well, what are the other referrals for, or triggers for offering peer support? And so I'll tell you what pre-COVID what were for many organizations. Christine can add if I've forgotten any, but anything that a caring, compassionate clinician would think might be stressful without waiting for the person to show stress is, an adverse event, particularly an adverse event with an error. A very just difficult patient, outcome, or, having to watch something really sad, regardless of whether, their care was perfect or not, being named in a lawsuit, being reported to the Board of Registration in Medicine. I have to add, unfortunately, because it's been increasing in the last couple of years, patient aggression is very upsetting to healthcare providers, whether it's physical aggression or just, emotional. It's verbal, I should say. Racism, discrimination, those are traumatic for healthcare providers, as they are for anybody. And so reaching out, if we know that has happened, that should be a trigger. Taking care of, trauma victims. There's all sorts of anything you think might be emotionally stressful. With COVID, what's different is that it's not an acute event, right? COVID is now a reality of being, of our time right now. And so there's no trigger that you're going to wait for. And so a lot of programs have done some modification, which is kind of routine reaching out. Or providing group peer support to say, look, this is so stressful for all of us. Let's meet, on whatever in the evening by Zoom or what have you. Or let's, we're going to have a peer supporter just slowly over the next month reach out to different people in his or her unit or division. So because we're just assuming, we're all stressed regardless of, some people more than others. But so I don't think it has to be an acute trigger. I think COVID has shown us it can be just these very, very highly stressful general circumstances.
Yeah, and then it's opt out.
Exactly.
Again, overcoming some of the stigma too.
Yeah. You never want to force people to talk. I think we know that from literature on crisis intervention, stress management. It can be harmful. And so it's a very gentle but very on a platter offer. Hey, some of us find it helpful. Is that something you'd like to do? I've been relying on it myself, or whatever you say to say. We're reaching out to everybody because this is so stressful right now for many of us.
Yeah. Just the right thing to do. Don, any thoughts and reactions from you?
Yeah, first, it's amazing, and I hope this becomes much more widespread. I put in the chat something I discovered a couple of weeks ago with my friend Ron Suskind, a Pulitzer Prize winner reporter who's published an article in the New York Times that I posted here that is really, really, really worth looking at. You'll see resonance with Joe and Christine's accounts, and he started an organization called Bongo, B-O-N-G-O, which I am really intrigued with, which has to do with liberating clinicians to talk about their experiences. There's a very interesting question which I have also from Chad Vargas. Chad asks, how do these programs extend from physician peer support to nursing and other allied health staff, and I'd even extend beyond to other employees than clinical staff in the healthcare settings you're in? Have you tried that, and what are some of your experiences or thoughts?
Yeah, when I was at the Brigham, we started the peer support program in 2008, and it was initially and through the whole time I was there for 10 years, post starting the program, it was for everybody. I will say, honestly, it focused more on clinicians, although there were times when we actually provided support for very exceptional circumstances to other groups, but it was for any clinician. And somebody was saying that, I think in the chat, that I think, which I agree with, is that it's helpful to make sure that if you're going to support nurses, you've trained nurse peer supporters. If you're going to support PAs, you've trained people within the same discipline. Now, when I started doing peer support at my organization that I was at, I did the peer support for everybody because I was the only one doing it. So you can do it for any discipline, but I think it's great if you assign someone within a discipline, and so those people need to be trained, and it doesn't have to be a perfect one-on-one match, the person doing the exact same thing. It's just somebody who would feel like your peer, I think, is the best way to look at it. So that hopefully that answers that question.
Yeah, we did start at the same time as our provider peer support program. We started a nursing peer support program, and that has extended to involve training some of our social work staff and other members of the care team because rightfully so, those individuals also need support. And I agree with Joe wholeheartedly that we can try to provide peer support, but one of the first things I mentioned was that we're trying to provide peer support from relevant experiences, and that can be difficult if you're not in that same role. So we've even had our emergency department has trained, has kind of like a subgroup of peer support within the nursing staff, because I think a lot of what we were talking about unfortunately, like patient violence against staff was really draining on our emergency nurses, and they felt that they could understand each other's experience and provide support around that. So we did a training session for that group as well.
There's a couple of questions coming up in the chat. Thank you for that. One is from Sherry, who shared peer support at the start of COVID but had low usage, so they've since stopped the sessions. Do you have any recommendations on increasing the use if they start them up again? And the second question from Kurt, how involved are unions in the programs?
I'm going to take the first one. Christine, I'm graciously giving you the second. One of the biggest problems with support programs generally is the poor utilization, especially by physicians, but all healthcare team members. And you can have beautiful programs, and often they're headed by employee assistance program, psychiatry, and they're just not utilized. It's really, really a common concern. My colleague Tim McDonald, who's done a lot of work nationally for peer support, he says, if you build it, they won't come, just for that reason. And so I think that's why Christine and I are stressing this. It's how you structure the offer, right? If I found that organizations, if they say, oh, we're having a group meeting, anyone welcome, or a drop-in session, it's just not going to be necessarily well attended. But if you say, our faculty meeting, for example, this week, we're going to devote a half hour to actually, kind of doing a debrief, if you want to call it that, and some peer support. Or if you do what Christine and I are both talking about, is you actually you email people and say, give me a call when you get a chance. I'm reaching out as a peer supporter, and you explain the program. Hey, I'm reaching out because we're checking in with everybody, and I just and you're not asking, by the way, on that offer, I don't ask people how are you feeling. right? Because most automatic answers will be, I'm fine, I'm good, thanks for checking. It would be more like, I wondered if, a lot of us have been really stressed. I wonder, and we find it helpful to have some peer support. I wonder if that's something you'd be interested in, because I'm happy to provide that. It's a very gentle but very relational offer that takes any barriers away. But I think these whoever asked the question about poor, or said they had poor utilization, I think it's all about how it's structured and offered.
Yeah, I would echo what Joe said about how important that initial contact is, and that it's well thought out and timed appropriately. So we have shied away from texting people or calling people or paging people unless they ask you to do that, because we don't want to disrupt somebody in the middle of their day. And so we've used email a lot to explain the program, and with the assumption that if somebody's checking email, they're probably in a little bit more of a down moment when they can receive that information. The part about buy-in, I think, is patience is key, as it seems to be with most things in life. And, I have seen programs that start up that don't have a lot of usage initially and receive calls from the people involved, kind of distressed, saying, what do we do about this? And the answer is you start to talk about your program in lots of different venues, as Joe mentioned. You start to talk about it at staff meetings. Have a slide that you can just put up. It's just one slide that shows what your program is, how to access it. Talk about it during onboarding sessions. Talk about it, put information in the break room about it, and really be patient that people will start to trust, because it's often a big shift in culture, and it can be very concerning for some. I also saw a question about how peer support can be used to mitigate poor staff-to-staff interactions, and that is a really great question. I think more than anything, peer support can be used to recognize signs of distress, and poor staff-to-staff interactions are usually a sign of distress. So we talk about some of the acute stressors that can lead to burnout, a really poor outcome, errors, challenging cases. I think about it in my mind as sort of those are like the acute causes of burnout, and then there's the more chronic to address. And I think that poor staff-to-staff interactions is often a sign of somebody who's in distress and is often not aware of it themselves. So you can reach out in those cases and say, notice that there seems to be some stress here. Is there something that we can discuss and help with?
And it's probably not enough, right? Because I think Joe would advocate for, in addition to a peer support program, a professionalism program. And this is another topic we could dive into deeply, but when there are issues of disruptive behavior, racism, things that have to do, maybe kind of veer into some of the personality disorders that we start to see. Joe, can you speak very briefly to some of the other supports you might need in addition to a peer support program to address some of those things?
Yeah, I think it's an interesting connection, because it is true that it's possible people might need peer support for some stressful interactions that they're going through. So not just as a marker that people who are behaving this way are more stressed, but also people who are behaving this way are causing a lot of stress for other people. And I think, maybe less than the acute phase of the pandemic, there's a chronic problem with how healthcare providers interact with each other that is well documented. So I think it's really important. What we talked about with peer support is it's at the junction of personal resilience, like how can I cope with these stressors, and organizational resilience, well-being programs, if you will. So if I was doing peer support for someone where one of the things that was really stressing them was this person is bullying me, or I'm just, I'm having such a difficult, interactions with this group of people or what have you, would be to give them to think about, well, you would hope that your organization has a place where someone can help with that. that's part of what I did when I was at the Brigham, was try to help people, not try, that was my job, is to work with people who are really stressed from, from these really difficult interactions, which have been known to cause acute and chronic stress. So what you'd hope is the organization has these structures that will help mitigate, and I'm going to say in the issue about professionalism, to remediate. People can change how they behave towards each other. They can, and sometimes they need coaching, sometimes they need all sorts of other things, but they can do it. But the organization has to say, we care about this. So I think that's where, as you said, there's a lot more involved with that, but I think it's not remote. It is connected to peer support.
And that growth mindset and believing that people can learn and adapt and change is been exemplified for me by Don Berwick. Maybe it's the pediatrician in you, but you're consistently reminding us that there's opportunities for people to change their behavior, and some really great resources from Joe and others to do so. And with that done, there's only a few more minutes left for the discussion. Any reflections for you based on what we've been hearing from Joe and Christine, and then folks in the chat?
I'm happy to hear others. Two things that keep occurring to me. I keep now being in meetings which suggest that this COVID situation is going to go on a long, long time. I was just in conversation with a big organization that's planning for 1 year before things are anything like back to normal, and I think that may be optimistic. So we're in this for the long haul, and so this program seems to be even more valuable. I guess the question I have is the question IHI always has, which is how do we spread it? What are the where is the traction here to take what sounds like a remarkable form of assistance to people that really need it? Go big. And so any advice we've got on that would be really, really welcome.
Well, I think what you do is you engage people like Jess Perlow and Don Berwick, who are experts in spread. It's such an important question. I think, the traditional way is publishing on this, and I try to do that, but it's hard. This is hard to get data for. And it's hard to get your stuff out there if you don't have data, to talk about program. Our group has published on this, but so that's the traditional way, which actually is good, but it's necessary but not sufficient. I think I don't know. I think I'm really pleased, Don, that for how much uptake there's been since COVID started. I'm just so happy that people are saying, we want to do this, and they have found the resources, which aren't huge. The necessity for them isn't huge. So I think it's already spreading. But I'm not an expert in that. How do you spread? And so I would ask my expert friends.
I would build upon that as well, that, if you look at, for our program, for instance, almost 70% of our referrals to the program have come since April 1st. So that's a significant uptick in referrals during this time. And so for people who are wondering, gosh, where could we start? I think if you look at the Medscape survey from 2020 that looks at physician burnout, upwards of 25% of people don't even know what's available at their own organization to begin with. And another quarter of folks are extremely worried about confidentiality. So I would use those two things as a guidance and go back to whether it's your work unit or your organization and look at ways that you could find allies in this work. And you don't have to start big. As I mentioned, we did a smaller training program for our emergency nurses. You can identify hotspots and areas of difficulty and develop pilot programs and then build on those as those demonstrate success. So we sort of did it in the reverse direction, and now we've been building around that. But I don't think it's just one way to affect change.
Yeah. Thank you.
I mean, if, Jess, I could just add one more thing,
Yeah.
and that is, so, I mean, since COVID, I've had a lot of asks to do webinars about how to build a program, podcasts about that. And so, you know, and there are others too. Mine isn't the only model, that's for sure. And so I just think there's a lot more out there now to have organizations be able to get started. It's not, again, it's actually unbelievably straightforward compared to some other programs that, you know, that I've seen. So the point is that there's more resources out there. You know, how to make sure people get a hold of them, I don't know, but we've been working with lots of different large organizations, obviously including yours, to say, hey, this is one way. It's not the only way. You know, and I know, I think that's what's really important, is to people to know that there's a menu of ways you can approach this.
Wonderful. We're going to chat in your contact information if you don't mind, Joe. So
Not a problem.
I can get in touch with you. Thank you so much. We've reached the end of our time together today, but as we wrap up, there's this survey that's going to pop up in the right-hand side. This will give us an opportunity not just to hear how you think today went, but also to give us some ideas for what you want to continue to explore in the series on this topic. I want to thank you, Dr. Joe Shapiro, Dr. Christine Hine, and Dr. Don Berwick. Thank you, Julia Nagy and Eleni Catcher behind the scenes, Vicki Minden, and Matt Morse for your help with today's program. And thank you, audience, for taking the time to participate. There was a really active chat and lots of resources shared. So we're going to capture those. Be on the lookout. We'll archive the edition of today's show. We'll post it to ihi.org by Monday. /caregivers. I think that's the full link. So you can check out the complete archive of the programs there on the website. This, as I mentioned, this special series, this virtual learning hour Caring for Caregivers series offered by the Wellbeing Trust with the support of the Wellbeing Trust will continue on a bi-weekly basis through September 11th. We skipped 1 week for Labor Day. But we're going to continue to feature topics related to the prevention, prediction, and mitigation of poor mental health and well-being amongst caregivers right now during the pandemic. And then while you're on the website, ihi.org/caregivers, there's a discussion board. So if you want to continue the conversation from today, you can see that there's a shared learning page so you can engage with fellow listeners, get support from peers, virtually, very low touch, light touch, and some real-time solutions to some of the challenges that folks are dealing with right now. Wishing everyone joy and well-being in your work. And from the Institute for Healthcare Improvement, I'm Jessica Perlow. Thank you very much.